Good morning. I'm Dr. Joe Mathew, and today I'm going to be talking to you about the try-in appointment. Now, there are two things that you must remember about this. One is the name of the appointment, which is try-in appointment, and the other is the name of the denture, which is called the trial denture. So you separate the two names clearly so that you know what you're talking about. The trial denture is the denture we are going to try in the patient's mouth, and the appointment is called the try-in appointment because that is where we are going to try in the trial denture. Okay, I hope I didn't confuse you on that, all right? So what we need to remember about this is, once we have arranged the teeth onto the occlusal rim, we have to verify the accuracy of the jaw relation. Okay, we have to make sure that it is right and it is verifiable, and if there's any mistake, we need to make it correct. So these are the three aspects that we need to test it, perfect it, and then verify that it is actually okay. So these three things must be done when we do a try-in. This is an essential part of what we're doing with a try-in denture. Okay. So how do we do this? Now, the thing is that we should never take it for granted that it is correct. Never presume that it is correct. Always verify. There are too many aspects, too many chances for error in the mounting, in the setting of the plaster on the articulator, the handling of your articulators, when you move the tentative jaw relation from the patient's mouth to the cast. There are so many areas of error that can creep in that can actually distort your actual jaw relations. And therefore, this is your time that you can actually check it in your trial dentures. You can actually, in your trial denture, you can actually place it into the mouth and you can check it if it is correct. So it needs to be accurate on the trial dentures. Okay. The appearance, the occlusion, and the comfort of the patient is dependent upon the accuracy of the jaw relations that you are going to make. All right. So this is a very mandatory step. And if you don't want to make any other painstaking corrections later on once the denture is processed, then this is a step you really want to be keen on, right? Right. So what's next? Well, there are some prerequisites before you record or verify your jaw relations. Okay. Some prerequisites. One, how do you do it? How do you actually come to the place where you're going to do the jaw relation? Primarily, if the patient has been wearing old dentures, it is a good idea that you advise the patient to leave the existing dentures out of the mouth for at least 24 hours before the appointment. This gives a chance for the tissues to rest and to be in a normal state, not in a compressed state. And the chance of you making a good jaw relation record are way higher when you are having the patient in this condition. Okay? An acceptable alternative, so some patients may not really accept the fact that they have to keep their dentures outside. So an acceptable alternative to that is probably to reline the dentures with a soft reline material, which will enable the tissues to heal back and come back to its normal position than being in a stressed out position. Okay, and that will help us. Okay, whichever approach is taken, give time for the soft tissue of the basal seat to recover. Give it adequate time, and so when you're making impressions and you're making jaw relations, is going to be really, really helpful. Okay, if this procedure is not followed, chances are that you will have the tissues in the distorted condition, which means that your base plate or the record base that you're making the trial denture on is going to be distorted as well, and that's going to cause all sorts of problems during the try-in appointment and even during jaw relation if you didn't follow this at the impression stage. All right. So what's the definition of try-in? Try-in is a process of placing a trial denture in the patient's mouth for evaluation. That's your GPT definition. Okay. It is also referred to as a trial placement. All right. The trial denture. The trial denture is the preliminary arrangement of the denture teeth that has been prepared for placement into the patient's mouth to evaluate the aesthetics and the maxillomandibular relationship. So in this definition, very clearly you can see there are two major aspects that you want to verify. One is the aesthetics. The other is the maxillomandibular relationship. When it comes to a maxillomandibular relationship, you want to test it. You want to perfect it if there's some small issue, and you want to verify what you've done to make sure that it is correct and you are not having any sort of doubt with regard to jaw relation. Because any doubt, and then you're going to have a step called processing, and processing errors are going to creep in, and then you're going to have a magnified doubt. Remember, in prosthodontics, I always tell my students, 1 + 1 is never 2. one mistake plus one mistake in prosthodontics always ends up with 5 big mistakes. It's a huge mistake at the end of the day, a huge problem that you find difficult to correct. So go step by step, go steady, make sure every step is right. So stages at which the try-in may be done. Now different people would have different ideas as to when the try-in should be done, and that's absolutely fine. Okay, so there are different places at which you can do it. Some people like to do the complete denture arrangement, teeth arrangement, and then do the try-in at one shot. Some people like to do the anterior try-in and then complete the posterior try-in at a different stage. Some people like to do the centric occlusion try-in first, that is the try-in where the teeth are centric occlusion, and then obtain the lateral records, protrusive records, and then perfect it to a balanced occlusion, then go for a final try-in. So there are different ways at which people like to look at this issue. Now, there are many approaches to performing a clinical try-in, okay? But I prefer to follow a preferential method. What do I mean by that? What I mean is that there are certain things I look at and think of as quick checks, and some things I think of as detailed checks, okay? So if I were to do a try-in, I would not take too much time verifying the record base, because I've already verified the record base in my jaw relation step, which precedes my try-in. So that's the kind of thinking that I have. So if I'm doing, after impressions that are coming in and doing my jaw relation, first thing I want to do is verify the record bases and all those things, because I'm seeing it in the patient's mouth for the first time. But if I'm now taking the same record basis and I've arranged teeth on it and I'm coming to a try-in, I wouldn't bother too much about the record basis, because I've already checked that in try-in. Unless I made some huge correction during my teeth arrangement, I had some issue and some huge correction, then probably I'd really want to look at the record base again. But otherwise, I would look at it quickly. Now, the things that are new as compared to my jaw relation in my try-in is that in my jaw relation there was wax, and here there are teeth. So the teeth are new aspects. So those new aspects, I'm going to look at it in a detailed way. So I usually like to separate my steps into things that I do a quick check on, things that I do a detailed check on, and the things that I do a quick check on are usually the things that I've already seen before and I've already verified in detail before, and now I'm just quickly checking it just to see I haven't missed anything or something has not changed. Okay, so that's what I look at. I also prefer to do the try-in in the same order that I followed when I established the jaw relation. Okay, so I will also prefer to do that, and that is, you have orientation relation, you have vertical relation, and finally you have the horizontal relation. Except for the fact that I'm not going to be doing an orientation relation this step because I've got my teeth arranged, right? And finally, I believe that you must have done your wax contouring, your festooning, whatever you want to do. You must have completed that before you do your try-in. Because if you're going to do the waxing, the wax festooning and all that thing after the try-in, chances are that you're going to change the slip support and the aesthetics may change. So for this reason, I'd like you to complete all your wax festooning works, all that stuff, except sealing onto the cast. Everything else, do it beautifully well as you would want it in the final denture, and then do your try-in. That will help a lot. Okay, so what are the clinical steps we do in a try-in? One, you want to evaluate the mandibular denture alone. Okay, you want to evaluate the maxillary denture alone. Then you want to evaluate the vertical jaw relation. That is a vertical dimension, just like I told you before. Then we come to the horizontal, where you're going to check the centric and the eccentric, mostly the protrusive records. Okay, and finally you're going to evaluate the facial and functional harmony with the anterior teeth. Okay, so what's the aesthetic aspect of it? Is it functionally good? And finally, we're going to look at whether the patient, how the patient feels, and what are the considerations with regard to the patient's acceptance of this arrangement. Okay, so this is a quick step, right? I put up there, do it fast, quick check, do it fast, all right? So here, basically, you're going to look at retention and support, which means the peripheral extension of your denture base. And you're just going to look for good extension. Is it overextended, underextended? And you're going to check the frenal reliefs, labial, lingual, buccal frenums. And you're going to check all the borders, right? If they are okay, if they are fine, you're just going to jump over and move from it. Then you're going to go into that's the retention aspect. You're going to move to the stability aspect. The stability aspect, to evaluate the stability, you're going to apply pressure on the premolar section on one side and see if the other side is rising up, okay? If it's rising up, it denotes instability. I presume that you would have checked this already in your jaw relation. You can check it again here, just in case there are some issues with the teeth that are there, but or some warpage that happened with your denture base, but you can just check it, okay? The cause of instability usually are the teeth are set too far outside. So this is where you need to pay a little bit of attention. Unlike the previous time where you probably had your rims correctly focused on the crest of the ridge, here in the process of arrangement, there is a chance that perhaps you or perhaps whoever did the arrangement, got a little sleepy, didn't really focus on it, and slowly but surely the arrangement went off a little bit buckly, right, too far outside, and this makes the denture start to tip, because this is one thing. The other one is there's improper adaptation of the denture on the pressures on the pressure side. Okay, so if there's an improper adaptation, you press it and something flexes and this side lifts up. So this is one main reason. The other one is you can also expect that the flange on the non-pressure side is highly underextended. So if it's not well extended into the vestibule, there's no retention or support coming from there. When you press this, it just lifts off. So, but I am presuming that the flange extensions and things like that would have been checked by you during the jaw relation. Here, my focus would be on the teeth arrangement. Did I arrange it on the crest of the ridge? Did I go far off, buccally, and is that causing the tipping or the instability of my denture base? Is the tongue space. Now this again is an area that can change because of the teeth arrangement. Okay, so usually the lower posterior teeth are arranged where into the neutral zone, where the tongue and the cheeks, the folds from both of them are at equilibrium. So this is where we usually arrange the teeth. But sometimes during the course of arrangement, maybe whether you did it or whether someone else did it for you, maybe you just got distracted a little bit, and we end up veering off and arranging the teeth a little bit lingually inside. In such an event, you have a situation where the tongue is cramped. So how do we check this, right? So we ask the patient to lift up the tongue slowly, and when he's slowly lifting up the tongue, if there's a quick immediate jerk of the denture, especially the posterior portion lifting up, chances are that the tongue space has been compromised. And you can see that very clearly. You can see the tongue trying to lift up and the dentures lifting up with it. So it's very obvious. So what are the usual causes for lack of tongue space at this stage? Not a jaw relation. At jaw relation is fine. So at this stage, well, one, you set the teeth too far lingually in. That's one thing, like I told you before. Second, you use teeth that were too far wide buccolingually. So your selection of teeth went wrong. You choose teeth that are too far wide, even though you place it on the crest of the ridge. The lingual aspect of the tooth is too wide, and so it's encroaching upon the tongue space. And the third one, remember when we teach you to arrange teeth, we usually tell you to arrange the teeth on the crest of the ridge, and that especially holds true for the mandibular denture. That's primarily because the mandibular teeth must be set on the crest of the ridge because the ridge is very thin, and you want to place it perpendicular to the ridge crest. Now, what happens is that once that is set, then, or once you've identified the line on which the crest is going, then you can transfer that line to the maxillary occlusal rim and you can arrange the teeth correctly. Sometimes, people don't pay much attention to it and end up arranging the teeth on the upper teeth on the crest of the maxillary ridge crest. That's going to create a problem because if you arrange the teeth on the maxillary ridge crest, obviously chances are very high that you have the teeth too far lingually or palatally already. So if you want to get a good occlusion, the mandibular teeth that are following are going to come too far lingually. But generally, you want to place the mandibular teeth on the crest of the ridge, and the maxillary teeth needs to get to occlusion with the mandibular teeth in that position. You don't change the mandibular teeth's position to fit the maxillary. That is wrong. So you want to put the mandibular teeth on the crest of the ridge and the maxillary fits into that. How do we do this? Because we usually arrange the maxillary first. So you need to identify where the mandibular ridge is, where the ridge crest is, transfer it to the upper occlusal rim, then arrange your teeth to follow that line. Then naturally, when you arrange the mandibular posteriors, it is going to follow in line correctly. If you do it any other way, chances are that you've got it either too far out buccally or too far out lingually or sometimes even diagonally. When I say diagonally, I mean the teeth at some point is in the right position and at some point is either flared out buccally or going in lingually. So take care of this aspect. Okay. You need to also differentiate. See, when the tongue is rising up, okay, if the movement occurs after the tongue rises to some distance, it's probably because of the overextension. That means in the posterior portion, in the lingual pouch area, if there is an overextension, then you will see that as a rise of the denture after the tongue has risen up to some degree. The other one, if there's a cramped tongue, you'll find as soon as the tongue is slowly lifting up, you'll see immediately the denture picking up. Okay. The other one, the tongue is raised up to some degree, and then beyond that degree, when the tongue tries to move up further, you find the posterior part is coming up. That is commonly because of an overextension in the lingual aspect. All right. So this is just a diagram to show you how it can be way far in and create a tongue compromised tongue space situation. Right, here again, the height of the occlusal plane. This is also very important at this stage. Okay, as you can see here, the teeth, you can see the occlusal aspect of the teeth, the buccal as well as the lingual aspects, which means that the plane of the teeth is higher than the tongue. The tongue is here, the plane of the teeth is higher. What you really want is you want the tongue to be over the teeth. At least the posterior border of the tongue needs to be over the teeth, so that when the patient is moving and talking, the tongue is moving around, the denture is held in place. You don't want the tongue to be under the occlusal table of the teeth, which gets lifted up or unstable because the tongue is trying to move. So in this aspect, you can see that the lingual borders of the teeth are covered by the lateral borders of the tongue, which is the right way the arrangement should be, the plane level should be, the height of the plane should be. Okay. Evaluation of the maxillary trial denture. Again, the same thing. You're looking at retention and support, you're looking at all the peripheries, the extensions, the frenum reliefs, right? The important aspects here, again, I hope you've checked it in the jaw relation, but important aspects to check is the overextension in the distobuccal flange. You want to ask the patient to open the mouth wide, and if there is a displacement of the pain or anything, you will know the distobuccal flange area of the maxillary denture is overextended. Then you can, if there's an underextension that you have to, it's going to be really difficult to evaluate that at this stage, but you can, but you'll have to go through with a mirror and check it out, especially if you have created some underextension for whatever reason, if the denture was not, the trial denture was not going into the cast, onto the cast, or whatever reason you reduced it. So next we have is the evaluation of jaw relation, and obviously here we're going to do the vertical and the horizontal relation. We're going to check those because the ordination relation, we hope that you've done it right and you've checked it and made sure that it is perfect at the time you did it. So getting into the vertical relation, and just before that, let me just go through this flow chart. You have a trying stage, and you're going to verify the mandibular denture base, the maxillary denture base. If there are no issues, then you're going to proceed. If there are issues at that stage, better to remake the denture base and go. Okay, and this, very sadly, I would say this is not the place to do it. If you would want to do this, this should be checked at your jaw relation step, so that you don't have to make a costly correction now. Okay, so if there are no issues, proceed, and then you're going to come to the first thing that you want to verify, that is the verification of the first tooth contact in centric relation. This can create major issues, right? So this can also affect your vertical relation. I know centric relation immediately reminds you of horizontal relation, but hang on. This can create issues in your vertical as well, which is the reason why I'm going to talk about this just in a little bit, and then I'll tell you what needs to be done. So once the first three issues that you have here are going to be an anterior open bite, a posterior unilateral open bite, or a posterior bilateral open bite. So in this case, you're going to repeat the jaw relation, either using a partial jaw relation or a complete jaw relation. You're going to do something to repeat the jaw relation to correct this problem, right? And if that issue is not there, then another possible issue that's going to be is there's a contact and then there's a slide to come into that centric occlusion. So centric relation, there's a contact, but the teeth are not in centric occlusion, and it slides to come into centric occlusion. If you see this sort of a thing, then again your arrangement has gone wrong, and this will need to be corrected when we check for horizontal relation. But on the other hand, there can be another problem where you're trying to close and there's one tooth, interfering in the occlusion, creating a kind of a disparity in the occlusion all over. So identifying that and correcting that would be a minor thing to do, and you could do that. Usually that should not happen if your articulation was right. That should not be the case. But in case that has happened, you can always correct that. So if there are no issues, then you're going to proceed to the vertical jaw relation. Now, before we get into this, let me tell you how to guide the mandible into centriculation. Very important. You need to get this straight, because if you don't get this straight, it's going to be difficult all over. Okay. So how do you guide this? So I put 4 simple steps. Okay, but 1, 2, 3, 4 there. Support the lower denture. You put the lower denture in the patient's mouth. Support the lower denture with the patient guided into centric by the thumb. Okay. So you want to put the thumb on the anterior inferior aspect of the chin. So you're going to actually just do it like that. Anterior inferior aspect of the chin. Your fingers are going to go into the patient's mouth, and the index fingers are going to go bilaterally and support the flanges, the buccal flanges of the lower trial denture. Okay, you're going to support it with the index finger. The patient. The idea is that the trial denture is seated, okay, in an inferior anterior direction. It's not sliding back. It's inferior anterior direction, and you are guiding it to remain in place. This is the idea. Okay. The third, the patient is asked, once you've got this position in, ask the patient to go as far as back that he can, and then close his mouth till he gets a feathered touch on his back teeth. Okay, so you've got your finger position, inferior anterior, you've got your index finger inside the buccal flange of the lower trial denture, keeping the denture without pushing off backward in an anterior inferior direction, and ask the patient, okay, now you go back and close your mouth gently till you come to a feathered touch contact of your back teeth. When he comes there, as he's approaching there, actually the dentist must take off his hands from the buccal flange. Actually, you can go a little bit in, because usually when you do put the fingers in, you tend to stretch the lips and the cheek, and that's not a great idea because the denture tends to shift. So as you approach that centriculation point, just move your fingers in, thereby easing the pressure on the lips as well as the cheek, and the dentures you just supported it to just stay there, and it's coming into that first contact. When the patient comes to first contact, ideally I would like you to just give the contact, open it out again, give the contact again. Okay, once the patient is sure of that first light contact, 1 or 2 times you can practice it. Once the patient is sure of that first contact and you can see the first contact, then you ask the patient to close tightly while you observe it. At that point, if there's a shift, you can see very clearly that there is a shift. So first get him to practice that position. All right. So that is the 4 simple steps to do the to guide the mandible into centric, right? And from there we should start doing all of our verifications. So you're going to verify the vertical jaw relation and the vertical dimension of that. So this is something that you need to examine carefully. I put a sticker up that says, do it slow, examine it carefully. So place the trial dentures together in the mouth. Remember, changes in the centriculation can oftentimes interfere with this. Ask the patient to move to centric like I told you, and there can be 2 possibilities. The 2 possibilities, 1, at this point, verify if there's any major discrepancy like an anterior open bite, a posterior open bite, unilateral or bilateral. Okay, if it is so, repeat the jaw relation by doing a complete jaw relation. Maybe you want to remove the whole thing and do it all over again if there's too much of a problem. Or you can do a partial jaw relation, which is like a posterior rebite or an anterior rebite, depending on what your teachers guide you to do. Because they have the experience, they can really help you to identify what needs to be done. So that is something that you can do. 2, the other problem is at this point, if there's any minor, sometimes it's critical, okay, discrepancies where the patient is opens and repeats his closure, but when he's closing it tight, you find that there is an error, the touch and slide. This touch and slide must be corrected at the horizontal jaw relation step. Okay, so if the patient is able to close and there is no obvious huge major open bite situations, there's some touch and slide, wait for the next step. Right now you go ahead and you check the vertical relation, complete the check of the vertical relation, right? So most of the time it's the dentist who's going to make the judgment of whether the vertical dimension is okay, whether it's fine, right? But you can also use a lot of aids. One is pre-extraction records that you can use. The other one is if the patient is having an old denture, he's used to a certain occlusal vertical dimension, right? You cannot go very far from that most of the time because the patient will not really accept that. So you can kind of judge with that. This is another one, good indicator. Another one is phonetics and aesthetics. The patient's face looks too stretched out or too dished in. Okay, how the patient speaks, is it clear, not clear? Then the facial measurements, right? How the facial expression looks, does it look like a drooping face because the vertical dimension is too low, or very stretched out face? So these things you can check. Lip length with the anterior teeth. The patient is struggling to close the mouth, or patient is he opens the mouth a little bit. Normal speaking, you can see a lot of teeth. So the lip length relationship with the tooth, that is the visibility aspect. All these things you can check at this stage. So you're going to use all these things like the pre-extraction record, intraocclusal distance the patient is accustomed to, phonetics, distance at rest, right, facial dimensions, expression. So some of these things, minor issues, can be adjusted at this point. Some of the major things, probably you have to repeat the jaw relation. It all depends on how severe the problem is, right? And if there are no issues, you're going to go into horizontal jaw relation. So in evaluation of horizontal jaw relation, you have centric and eccentric relation that you're going to look for. Well, of course, what is the rationale for making these records? See, in no situation can you 100% say that my records are perfect or my tine is perfect without actually seeing it on the articulator. Really, because the denture really rests on soft tissue and it can always move. And because of that, actually, a lot of dentures just work fine because the tissues adapt. But my point is that you can only see gross occlusal errors by visual observation, okay, in the mouth, and you can't see the lingual aspects. So there's a lot of limitation that we have. So oftentimes we don't rely only on visualization for the final determination of this record. We want to know if the jaw relation is right. We are going to take a record from the patient's mouth, and we are going to verify it on the cast in the articulator, and we're going to check if what is on the articulator and what is in the mouth, or rather what is in the mouth is the same as what's on the articulator, and there's no discrepancy between the two in terms of jaw relation. This is what's important. I can have a relation in my mouth. I need to take a record, put it back on my articulator and check, is there any difference? If the articulator and the mouth is the same, we are good to go. If there's a discrepancy, we want to correct it before we go further, because anything that we do further without correcting it is going to create a big problem. All right? So you're going to verify horizontal jaw relation. You're going to verify it in two different ways. You can either do an intraoral method or an extraoral method. Obviously, I told you verification is best done on a cast. So obviously, you're going to go back to the cast at some point. So you're going to verify centric relation, eccentric relation, and finally you're going to look for facial functions and harmony. So in evaluation of horizontal jaw relation, verifying the centric, you're going to look, once the vertical dimension is acceptable, you're going to look for the centric relation, and you're going to do an intraoral observation of this intercuspation and centric relation, and you're also going to do an extraoral articulator method. So in the intraoral observation of intercuspation, you're going to guide the patient to centric, right? And like how I told you before, and then if there is an error in centric, how will you know it? Well, you can have a space between the upper and lower posterior teeth at the first contact, or the lower teeth are sliding over the upper teeth after first contact. That means there's a slide. Then there can be a shift of the lower midline, which means there's a lateral slide, right? So these are the three ways in which you really can see if there is an error in the centric relation. So an intraocclusal check record must be made to verify the relation. Otherwise, a new centric relation record must be made. So what you're going to do is you're really going to put some intraocclusal record material, take a bite registration record, you're going to transfer it to an articulator and verify if it's the same as what is in the mouth. Okay? If you feel there's a problem, you're going to remove the teeth in the posteriors and you're going to do a repeat of the centric relation record. So this is the first situation. The teeth are contacting like this initially, and then they slide. See that? They slide into occlusion. This sliding is not good. You can also have a midline shift that shows a lateral slide. So the three different situations, right? like I told you before, three different situations. There's a space between upper and lower, right? And then there's a slide that comes into occlusion, or there's a space continuously. Okay? If there's a space continuously, obviously you've got serious errors in occlusion. So, or there's a sliding in coming into occlusion, or finally there's a lateral shift. So, any one of these. Errors in mounting can prevent some teeth from intercusping, okay, after first contact is made. So you need to really get the patient to stop at first contact and then ask him to bite and then see how it is, whether it's sliding or not. The amount of this error will be magnified when the inclined planes contact. Okay, so for this reason, you need to check that all teeth have uniform contact at the same time in the mouth, like in the articulator. Okay. All right. So evaluation of horizontal jaw relation. Again, how to make the intraocclusal check records. How do you do that? So if the mounting is incorrect or you have a doubt about it, a preliminary observation of aesthetics is made. Now, we need to make an observation of the aesthetics because we are going to have to decide where it's going to close, right? Now, you don't want to change the vertical dimension and you're going to repeat the horizontal relation. When you do that, patient can overclose. Patient can overclose or patient can underclose. For this reason, before you remove the posterior teeth, we want to check the anterior aesthetics. We want to check if the parameters of the anterior teeth are correct, if the overjet and overbite are okay. If they are okay, then sometimes I take a pencil and mark the limit of the overbite with the posteriors on. So I have that 2 mm mark. So I know when I remove the teeth and put the wax and ask the patient to bite, I know I can stop it when that limit is reached. Because I've already drawn, at this point I've drawn, when the upper teeth is there, I've drawn a line on the mandibular teeth that tells me exactly. So I keep, okay, bite, 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 keep biting, 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 and stop. No more biting further, right? And no biting less. So I can keep the vertical dimension stable. For this reason, you need to check the anteriors first. If the anterior teeth are not placed to support the lip properly or there's an issue in the position, correct it now before you remove any posterior teeth. Okay? The vertical overlap of the anterior teeth is carefully noted. That's what I told you, right? This is important because the vertical overlap will be the thing that will guide you into how much closure is permitted, right? So once this is done, then the posterior teeth are removed from the lower occlusion brim. Both the occlusal limbs are placed in the mouth, and impression plaster or any interocclusal bite registration paste is mixed and placed on both sides of the lower occlusal rim in the molar and premolar region, and the patient is asked to close slowly. Now, this is where he can close too much or he can close too little, which is why you need to recruit it into centric and ask him to close slowly till his mandibular teeth over or goes under the maxillary teeth till that line that you drew. Till that line that you drew for overbite. When you get there, you know this is the right place. Stop. The vertical dimension is right. Stop here. Okay. So that's what you do, right? And yes, I think that's really what's written all over here. Okay. And once you do that, then you are good to go. So there's an alternative method that they use with beeswax, right? So here, basically, the same thing. You can see that the teeth have been removed, and they put wax in the posterior region, and they put wax in the anterior region as well. So this is a tripod method where the entire rim is not refabricated, right? Just the three areas, the anterior and the two posteriors, have a bulk of beeswax, and then you ask the patient to bite, and when the bite is reached a particular point, you are going to stop. So that this means for this, preferably, personally, I prefer to place this wax first, the anterior wax first. I do not remove the posterior teeth. I place the anterior beeswax first. I ask the patient to close. When the posterior teeth are in occlusion, right? The vertical dimension is stable. Once I get that, then I make a marking on my beeswax. So I have a clear line on my beeswax that tells me where to stop. Then I remove the posterior teeth. I place my beeswax in the posterior two aspects, and then I ask the patient to close again till the mandibular teeth come behind the maxillary till the point of that line that I made. Then I know my vertical dimension is right. my focus at this point is to get it into the right centric and make sure that the vertical dimension is maintained. Okay, moving on, you also have an extra oral articulator method. In this method, again, you're going to make intraocclusal check records. So I told you, without making intraocclusal check records and checking it on the articulator, you really can't say if it's accurate, because intraorally you can observe only gross errors. So you're always going to do that, but the first case I told you, just take a record and check it if it is the same. Second case, if there is a problem, you're going to remove the teeth and do the posterior rebite. Here again, you're going to do a check record, and if it's okay, fine. If it's not okay, you're going to have to repeat the jaw ablation. So again, the centricalization is checked or verified by an external method, and observations are made on the articulator rather than in the mouth. Here, two things that you must remember. We're taking two liberties here. One is that, first of all, the thing is that this technique is very attractive because it's easy and it is much more achievable, okay, and very effective. It has been proven time and again that it is very, very consistent in the results. So this is a very good technique. But the liberty we're taking is that when you put wax between the two opposing teeth, obviously, and you're saying that the teeth should not contact through the wax to the opposing teeth, obviously there's going to be a slight increase in vertical dimension. So a purist is going to say, okay, then you should have a kinematic face bow for this kind of a thing, and that should be the way it's done and all the story. Yeah, yes and no, okay, because we're going to overlook that argument primarily because see, there's no conclusive evidence saying that is a state of affairs. Number two, because clinical practice over years have proven that this is a repeatable and a predictable, that gives repeatable and predictable results. For this reason, we're just going to go ahead and we are going to take this liberty and going to do this step. Okay, so it's very simple. Here basically you are going to, the purpose, what is our purpose? We are using an external method to determine whether the position of the teeth in the mouth is the same as that which is in the articulator. This is our idea. So you're going to take alu wax, okay, which is a bite registration material, and we are going to place it on top of the teeth, posterior teeth. We're going to adapt it onto that, and then we're going to seal it with a heated instrument, and we're going to put it in a water bath that is about 130 degrees Fahrenheit or approximately about 54 degrees Celsius for about 30 seconds. Now the time the wax is in the water bath is important, because otherwise you will end up with a situation where the wax is not soft enough for the bite. Now the other thing that you must remember is when you're adapting the wax onto the teeth, make sure the teeth is dry. If the teeth is wet, the wax may not adhere well, and that could create all sorts of problems for the adaptation of the wax onto the denture teeth, and this may cause slipping of the wax and the records go wrong, all sorts of things. So you need to dip it in the wax for at least 30 seconds. Okay, make sure that the wax is uniformly and evenly softened, and then you're ready for the bite registration or the intraocclusal check record. So you're going to guide the patient into occlusion, centricalization, just like I told you, the 4 simple steps, right? And the patient is asked to close into the wax until a good index is made. Care must be taken the patient does not penetrate through and through. So the upper teeth must not penetrate through the wax to the lower teeth. It's very important that you don't do that. Okay. So keep the occlusal pressure minimal. So see here, you can see he is guiding the teeth and his fingers are, holding onto the buccal flanges. And as he approaches the centricalization position, you can see that the cheeks that are retracted like this have become eased out because he has moved his fingers away, and he has come very close to the 2 mm vertical overlap, right? And at this point, wait for it to set, take it out, put it in some chilled water, take it out once it's well cooled, and your records are ready. When you look at it, it should be nice, clear records, right? And there is no penetration, and it is at least about 1 mm deep records, which are ready to be mounted. Very clear imprint that you can mount with. So once we have got this record in the mouth and you've checked it, you're going to take it out, you've chilled it, right? And then you're going to put it back into the mouth and you're going to verify it again. Now this time the patient needs to close from first contact to full closure. There should be no slipping, sliding, talking, tilting of the denture. So if this is the case, then you deem that this record is good. If the record is good, you can go ahead and verify it onto the articulator. But if the record is not good, if you see some movement, you want to repeat the procedure and make sure that it is good before you go ahead. Okay. Once the record is good and it's acceptable to you, you're going to then take the mandibular denture, put it on the cast, wash it from his mouth, wash it, chill it, put it on the cast, and you're going to lock the articulator in centric. Okay, depending on whether it's archon or non-archon, find out where the centric is, because it's another whole thing in itself. Find out where the centric is, lock the articulator in the centric position, and then bring the maxilla to closure. As you come to closure, if they fit perfectly, then it shows that the relation that you have in the mouth is exactly the same as that which is in the articulator, and your jaw relation is perfect. It's verified. But if there is a difference, then you know that somewhere your jaw relation has gone wrong and your horizontal relation is wrong. So then you have to do a repeat of the jaw relation, whether it's a posterior jaw relation or unilateral or bilateral. So in that case, if you're doing that, then you have to remove the posterior teeth, place the wax in that location, and do the forcible steps, guide them into centric, take a record, and re-articulate the mandibular cast. So once the centric has been verified, then you have the eccentric position. The eccentric position really, the one that we really like to focus on is the protruser. Okay, so this is the only one that you can use, and this is the one that you can use only if you're using a semi-adjustable or a fully adjustable articulator. No other articulator will allow you to do a protrusive check record. But you can do when you find that there's a gross error in the horizontal jaw relation, right? So you can use plaster intraocclusal records or any other material after the anterior teeth have been arranged for aesthetics, okay? And after both the centric relation and vertical relation dimension have been verified. Once these are verified, you still want to go ahead and check the protrusive record, you can do that, right? So in that case, why they say it's important that the anterior teeth are set for aesthetics and function is because that incisal guidance is going to play a role in protrusive records. So the patient is going to bring the mandible forward and it's going to be guided by the maxillary incisal aspect. So if this is wrong in any sense, it's going to change everything. So make sure this is right in terms of his aesthetics and phonetics and everything, and then you can ask the patient to slowly bring the teeth to edge position. There will be a space between the two, and you can make your protrusive record. Now, what you need to remember here is that if there is not enough overlap, that means if there is not enough space between the protrusion or the horizontal overlap enough for getting a record, then you will have to ask the patient to move the teeth a little more further forward. Usually you need from centric to edge, you will need a distance of at least 6 millimeters, right? So this minimum is a requirement because most of our instruments don't, they have mechanical limitations. So that is sort of a requirement that we need to have, that you need to have at least that much space for material to actually flow in and get a good record. So in these cases, make sure you ask the patient to move a little more. So you check, evaluate how many millimeters is it moving approximately. If it's moving close to 6, it's a safe place for you to get the record without protruding further. But if he comes from centric to edge and you feel it's just very, very small space, maybe you want to ask him to move a little bit more further before you make the protrusive record. Okay, once you've got this record, right, you mount it into the articulator and you open up the, here you're going to open up the centric locks and you're going to check how the condyle is traveling on the path and if the path is accurate and the movement of the path is accurate with the protrusive record. So in eccentric records or lateral records for the horizontal jaw relation, honestly, the displaceability of the mucosa is a big problem, because of this, it's very difficult to get accurate lateral records. Okay, and again, most images or articulators don't accept a lateral record, and for this reason, honestly, I feel, and the authors of many books say it's not practical and probably not even needed to do lateral records for complete denture prosthodontics when you're doing a verification. Okay, in some situations maybe, but most of the time not really necessary. Another area that you want to really look at in detail and put there, examine carefully, is the harmony of the patient's face. So you have a midline. So facial and dental midline must coincide. Then you have the anterior plane. The anterior plane, the incised edges of the upper anterior teeth must be set with harmony to the lower lip. Third, you have lip form in profile. Turn the patient's face. You want to see that the lip form is adequately supported. It's not too much bulging out, not too protruded, or not too dished in. If it's well supported, you will find that the border is, the mucocutaneous border is up and the wet line is seen. Okay, and that is how it should be. The contact should be between the wet line to wet line and not the mucocutaneous junction to mucocutaneous junction. So if it's unsupported, you probably have that look, and so it's important that it is well supported. Well, the other one is the amount of tooth visibility. The patient speaks. How much of tooth can you see? Can you see any teeth? Can you see no teeth? Or is it that just all teeth? So make sure that there is an adequate display of teeth that makes it look natural and not look too toothy, not look too much protruded out, not too much tooth visibility. Okay. Then characterization. Some patients may have had some, trademark characterizations that they would like to retain. So if they are, should I say, reasonable and practical, you can incorporate gladly those individual characterizations into the denture so that the patient will come out looking much more natural than what you are going to do with an ideal sort of a setup. And finally, we're going to look at the phonetics, right? So in the phonetics, we're going to look at the S sound, which is the sibilant sound, the labiodental sounds, which is the F and the V, and we're going to also look at the bilabial P and B sounds. So the sibilant S sounds, you're going to have the lip separate, the teeth separate, and the patient's able to clearly say S. There's not going to be an F. F. This is not indicative of the right positioning of the upper anteriors. Okay, there needs to be some space there so that the air can actually flow out. And S, a very small space between the tongue and the tissue, and the air flows out, and you get the sound S. Okay. You also have the labiodental sounds, the F and the V, where the tongue is in a much more retruded position, and when he says F, you are having the lower lip touching the upper tooth, F or V. Okay, and you have the bilabial sounds where B and P, where both the lips are actually in contact. So if the patient is not able to say that because you've placed your upper teeth far too much outside, then you need to go back in and place it a little more further in so that you can get these sounds accurately. Finally, after done all this, you like the denture, you like how it looks, that is only half the way. The real question is, does the patient like what he sees? So the patient needs to accept the denture, right? So patient must be given the opportunity to observe the denture, right? Usually you can tell them that yes, we look at each other from about 4 feet distance or meters distance. Nobody's really going to come in and look at it from very close proximity. So you can tell the patient that, but patients oftentimes like to take the mirror and look at it very closely. So I don't think we need to completely restrict them from doing that. Make them aware that this is how people see it. This is from the distance from which people see it, and let them have their freedom at looking at the tooth a little bit more closer. Okay, because they will enjoy that freedom that you give. As they feel that you are trying to hide something, they're not letting them have a closer look at what they're getting. Okay, so let them have a look. The patient, you should never complete your dentures until you get a final approval from the patient. Even when the patient indicates that, I don't care how it looks, whatever it is fine with me, don't take it for granted. Give them a full opportunity to inspect and approve the arrangement. It's a good idea to get a bystander, a close friend or a confidant, someone whose aesthetic judgment the patient values. So don't get somebody who the patient doesn't like. It doesn't really help. Get someone, ask the patient to bring someone who the patient feels can give a good aesthetic judgment, and ask this person to stand at a 4 feet distance apart and to evaluate while the patient speaks and smiles and talks, and take their input. Anything that is reasonable and practical, try to incorporate it. It'll go a long way. Okay, and when this bystander or the patient's friend or the patient's relative or whoever it is who's come with the patient is going to approve it, it instills more confidence into the patient as well, right? This is preferably someone who often lives in close proximity to the patient. It's very important, because if the patient this person is a person who the patient sees once in 6 months or 7 months, it's not going to help. You know, sometimes you have people returning from abroad, and the patient brings the daughter who's returned from abroad, and the daughter hasn't seen the mother in 10 years. Is not really going to work. So get someone who lives daily with the patient, who sees her in close proximity. They'll be a good judge of whether your teeth arrangement is close to what the natural was, whether it looks off, looks on. They'll be a good person to judge it. So yeah, if they give you some input, be open-minded to receive as much as is reasonable and practical, and tell them what the difficulties are if they make unreasonable demands, and come to a compromise somewhere. Because remember, you are not the final person to make that call. The patient is the one who's going to have the denture, and she's got to live with that denture for day in and day out for the next couple of months or years. And you're going to just deliver the, insert the denture, and you're going to forget about it after a couple of post-insertion recalls. So for this reason, make sure the patient has a final say and the patient is happy with the trial denture before you quit the try-in appointment. When you get the approval, make sure you get it on pen and paper. Make sure you get it signed out. Most places, I think it's now mandatory to get it signed out, an approval form, because once you process it, there's no going back. There's no going back and saying, oh, you should have told me before, or the patient says, that's not what I like, this is what I liked. It just doesn't work. So make sure you get it approved. Make sure you take some trial denture photographs in front of the patient, so the patient is happy, and you can always refer to them back. All right? And this also will tell you if you had any mistakes in your processing. Okay? So if you had a mistake in the processing and there was a problem, then that's going to be a problem. But at least you know the problem is genuine. At least you know where the problem happened, and you can always correct it. So our aim is to improve ourselves, not just to put all the blame on someone else or to push it under the carpet. So for this reason, take the record seriously, make a photograph, get a written consent, and then process your dentures. Process your dentures well, and they will replicate the trial dentures pretty adequately. Thank you so much. I hope you enjoyed this lecture, and I'll see you again with another new one. Bye-bye.